Hello and welcome back. So I'll be discussing a new topic in this series that will be an approach to a patient with vomiting and abdominal pain. So we'll begin the series with an approach to vomiting, which may be associated with no abdominal pain, diffuse abdominal pain, or poorly localized abdominal pain. So you'll understand why I am clubbing these two together subsequently in this series. So, just to start things off, first we need to understand what exactly is why does vomiting occur and how does it happen. So, what I've drawn is actually a schematic of the brainstem. Uh, Now, this line that I have drawn that divides the pons from the medulla. So, this is the pons and this is the medulla. So, this is the ventral surface of the pons and this is the ventral surface of the medulla. This is the dorsum of the medulla. So this will become the fourth ventricle. This is just to get your bearings regarding the anatomy. So what I've drawn are actually two structures within the upper medulla, including the vomiting center. So this star-shaped structure is actually the vomiting center. Now, the vomiting center essentially gives signals downstream into the parts of the spinal cord that innervate the muscles that are involved in the entire vomiting reflex. So that would include, the muscles that are involved in increasing the abdominal tone and the parts of the myonteric plexus that are required for dilation of the lower esophageal sphincter, as well as the subsequent reverse peristalsis that would ensue inside the esophagus. Now, see the mechanisms of now the rather the neurological mechanisms that underlie vomiting are the same regardless of the cause. And as diagnosticians, we are primarily interested in understanding why vomiting is occurring rather than how it is happening. So we'll go right into it. Now, the bluish structure that I have drawn there, that is called the dorsal vagal nucleus, and the dorsal vagal nucleus present within the medulla receives innervation, sensory input from the branches of the vagus that are obviously subserving the entire parasympathetic flow to everything below the neck, right till the chest and the abdomen. Now, so that is called cranial outflow of the parasympathetic system. Now, this obviously enters the brainstem via the vagus. As it enters the brainstem, the signals go into this bluish structure that is the dorsal vagal nucleus, and some other signals, the sensory input, also go into this reddish structure that is what we call the nucleus of tractus solitarius. So, this is your dorsal vagal nucleus. Now, this signal is processed and sent over to the vomiting center. So, vagal innervation naturally can induce vomiting. Now, the nucleus of tractus solitarius is this red structure here. The nucleus of tractus solitarius receives input from this yellowish structure. So, this yellowish structure is actually located outside of the blood-brain barrier and is a structure called the area prostrema. Now, this is outside of the blood-brain barrier and therefore can sample the serum, that is the blood the serum for any toxins that may be circulating in it. And if it gets activated, it then activates the nucleus of tractus solitarius and then secondarily induces vomiting. Now, the third structure that I want you to know about is the vestibular nucleus. The vestibular nucleus obviously receives input from the inner ear. So these are the semicircular canals within the inner ear, and they give input directly into the vestibular nucleus. And finally, the cortex through descending descending neurological input into the vomiting center. So in effect, the vomiting center can be activated through cortical stimulation. Second, it can be stimulated via vestibular activation. Third, it can be stimulated via systemic pathologies that activate the area prostrema and indirectly activate the vomiting center via the nucleus of tractus solitarius. Then, finally, it can be activated by efferents within the vagus that arise either from extra abdominal sources or efferents within the vagus that arise from abdominal sources. So naturally, vomiting can only occur due to one of these five mechanisms getting activated. So let's see what that translates into. So if one thinks about it, basically only the causes of vagal activation and systemic causes can also concomitantly cause abdominal pain. Okay, this is why I'm actually clubbing the two together. So when you take into account the presence of, or absence of abdominal pain, the causes of of vomiting change in their nature. So you can narrow down the differentials. So again, only systemic disorders through other mechanisms, as they can cause abdominal pain through other mechanisms, and vagal abdominal innervation, because obviously it is carrying the sensory fibers from the abdomen as it is, can also cause abdominal pain. So if there is no abdominal pain, these disorders become less likely, and if there is abdominal pain, they become far more likely. Okay. Now why I have said less likely is because there are some cases in which systemic disorders can just cause vomiting, and we'll just get to that. Now the coexistence of abdominal pain therefore becomes a very important diagnostic consideration in evaluation of vomiting. Okay, now let's just talk about the relationship between vomiting and abdominal pain in any given patient. So we'll talk about vomiting, the type of vomiting, what is the associated abdominal pain, and what is our inference regarding the association. So one is that vomiting may be the primary complaint of the patient, and there may be no or minimal abdominal pain. In that case, we can surmise that the activation of the vomiting center is being done by a non-abdominal origin pathology. So that would mean it is either from the cortex, or it is via the vestibular nucleus, okay, or it is via a systemic cause that does not causing abdominal pain concomitantly. Okay, so that is one possibility. Now the second thing is you could have variable degrees of abdominal vomiting, but there is significant abdominal pain, as in the patient has complaints that there is the abdominal pain is a significant complaint, is a clinical issue for the patient. So that abdominal pain can then be diffuse, that is it is present all over the abdomen. So that indicates it's a systemic disorder that is causing abdominal pain, because systemic disorders are not likely to cause, prefer one area of the abdomen over the other, or one organ over the other. The second is it could be significant, but it could be poorly localized, as in the patient cannot exactly say where is the abdominal pain. Okay, so this we'll see happens in two situations. One is when there is chronic intra-abdominal causes of pain, and when there is functional abdominal pain. And finally, you can have significant but highly localized, as in the patient is able to clearly say that the pain is arising from this particular region in the abdomen. So this could be pain that has been referred into the abdomen from an extra-abdominal structure, or it could be true intra-abdominal pain that is causing the abdominal pain. So in these situations, presence or absence of vomiting does narrow down the differential, but it is highly specific to what kind of abdominal pain it is, and we'll get to that just subsequently. So that's how I like to approach a case with vomiting and abdominal pain. Now, in this discussion, we'll be discussing, we'll try to deduce the causes of vomiting without any abdominal pain. We'll try to understand what is called functional vomiting. What are the functional vomiting syndromes? Now, please note functional is under in double quotes. We'll deduce the causes of significant and diffuse abdominal pain, which may or may not be associated with vomiting. We'll try to deduce the causes of significant but poorly localized abdominal pain, which again may or may not be associated with vomiting. And under that, we'll try to understand the special mechanisms by which this somewhat contradictory statement is explained, as in the pain is significant, but the patient cannot say where the pain is localized. Then we'll try to enumerate the possible underlying causes of such pain. And finally, we'll end with an understanding of what is functional abdominal pain. So vomiting, we'll start off with vomiting without any abdominal pain. So again, I like to divide such vomiting into two types of two subdivisions, that is acute and chronic. So again, like I said, the input could be from the cortex. The input could be from the vestibular apparatus, that is the inner ear. It again could be a part of the cortex, but a psychiatric disorder, that is there is no structural pathology in the cortex. Or it could be still vagal activation, but vagal activation without the sensory fibers from the vagus getting activated. The abdomen, that sensory fibers that serve the abdomen getting activated. So, intracranial acute disorders could be anything like acute or subacute meningitis and cerebrovascular accidents, but actually, literally anything, any type of intracranial acute pathology could cause vomiting. Now, chronic causes would include chronic meningitis, intracranial space occupying lesions, and hydrocephalus. Now, in case of the activation of the vestibular apparatus, all causes of peripheral vertigo cause acute vomiting, and we'll be talking about peripheral vertigo separately. So we'll be talking about vertigo and differentiating it from incoordination and imbalance separately. So I'll not go into that right now. Now, the only cause of vestibular apparatus that causes chronic vomiting is benign paroxysmal vertigo. So that is the only cause that causes chronic. In acute, all other causes of labyrinthine activation are acute. Then psychiatric disorders typically cause chronic vomiting. That would include anorexia or bulimia nervosa and depression. Again, if you're suspecting this, refer the patient to a psychiatric care provider. Now, in case of vagal activation without concomitant activation of abdominal sensory fibers, that would include cardiac vagal fibers getting activated, say due to myocarditis or ischemic heart disease. And this typically is obviously an acute process. So as you can see, vomiting without any abdominal pain. The patient completely denies abdominal pain, has a limited differential diagnosis. Now, vomiting with minimal or likely insignificant abdominal pain is likely due to direct area prostema activation. So it is important to remember which receptors are located within each part of the vomiting, the centers that receive the signal for vomiting. So the area prostema has the most wide-ranging receptor expression. It includes the M1 muscarinic receptor, the H1 histaminergic receptor, as well as the 5-HT3, that is the serotonergic receptor, the only serotonergic receptor that is a ligand gated potassium channel, and then the dopaminergic receptor. Okay, so these are the area prostrema. Sounds fancy, therefore it expresses all four receptor types. Now, in addition to that, in Harrison they've mentioned thyroid disorders. Now they've mentioned thyroid disorders, which could be hyperthyroidism or hypothyroidism, but they've said thyroid disorders. So essentially, both can cause it, although hyper is much more likely to cause it. And then metabolic disorders, specifically hepatic failure, has been mentioned. Now, uremia also causes the vomiting, but usually there is concomitant abdominal discomfort or there will be some abdominal symptoms. Okay, we'll get to that just now. If there is no vomiting and the pain is also very none or very minimal, you may want to just observe the patient and there may not be requirement for any investigations. Coming to functional vomiting, so there are multiple named syndromes under this category. We've got chronic nausea and vomiting syndrome, you've got cyclic vomiting syndrome, you've got cannabinoid hypersensitivity syndrome, and rumination syndrome. Okay, now the important thing is we will talk about functional dyspepsia and your irritable bowel syndrome, and it may be a part of functional dyspepsia and irritable bowel syndrome also, but then the primary complaints are slightly different. Okay, so we'll restrict the present discussion to these four entities. So let's talk about them. So we've got chronic nausea and vomiting syndrome. We have cyclic vomiting syndrome. We have your cannabinoid hypersensitivity syndrome, and we're going to compare them. So we'll compare them clinically. So the first thing that we'll talk about is the patient profile, the gender, race, age, family history of the patient. Now, importantly, it is only significant for cannabinoid hypersensitivity syndrome, in which case males are more affected than females, possibly because of higher prevalence of cannabinoid usage. Now, chronic nausea and vomiting syndrome is defined by the presence of vomiting lasting for more than or equal to a week. At least 1 week it has to be there. It should be bothersome to the patient. The patient should complain that they do not, they are troubled by the vomiting, and and there should be nothing else associated with it. So there are no associated features. Now, cyclic vomiting syndrome is characterized by very periodic, discrete episodes of vomiting without any other clear localizing or diagnostic features. Now, again, cannabinoid hypersensitivity syndrome is also periodic and has discrete episodes of vomiting, but is related to cannabinoid usage, that is usage of cannabis and its other products. Cessation of cannabinoid use actually causes significant relief to the patient, and that is diagnostic. So again, chronic nausea and vomiting is not associated with anything. There are essentially no associations. Then we have cyclic vomiting syndrome, which is actually probably just a type of migraine. So it is associated with other forms of migraine, and on functional assessment of gastric emptying, it is associated with increased rates of gastric emptying. Now, with the cannabinoid hypersensitivity syndrome, there is a epidemiologically, defined prolonged association with a habit of prolonged bathing or taking showers. Okay. Now, coming to the next category, subcategory, that is just significant and diffuse abdominal pain with or without vomiting. So we have diffuse abdominal pain, significant or diffuse abdominal pain with or without vomiting. Now, here I like to talk about with or without vomiting. So I divide it into, yeah, with vomiting and without vomiting. Okay. Now, when it comes to with vomiting, the both causes. Now I use a mnemonic here, that is CAMP. Okay, so or cyclic AMP. So the thing is that it is diffuse, it's a systemic problem. So like cyclic AMP is diffusely used second messenger. I use that as a mnemonic. So C here stands for C1 esterase inhibitor deficiency. Again, very rare. This is hereditary angioedema. Okay. Now, C1 esterase deficiency has already been discussed under approach to rash part 2.2, that is superficial dermal disorders and urticaria. Now, A stands for Addison's disease, which is usually causes chronic diffuse abdominal pain. This is likely due to mesenteric hypoperfusion. Okay, but and therefore, because there is mesenteric hypoperfusion, gastrointestinal motility will be decreased, so vomiting becomes less likely. Then M stands for mast cell disorders. Again, these are rare causes, but something that one must consider. Then we have the second M, that is Mediterranean fever. This is because it causes peritonitis. Okay, and the peritonitis can become so severe that the patient develops vomiting because of the pain. Okay. Now, then we have P. P would stand for porphyria, again a rare cause, and P also stands for hyperparathyroidism, and essentially any other cause of abdominal, any other cause of hypercalcemia. So it actually stands for increased calcium. Okay. Now, then we have three other causes that are very self-explanatory. That is DA. So they are, DA, you should remember them. That is your diabetic ketoacidosis, and this is usually an acute process. Stands for uremia and H stands for hyperlipidemia. Okay. So these are the seven causes of vomiting, which of diffuse abdominal pain with or without vomiting. And these are important clinical considerations. Okay. Now, in specific situations, lead poisoning and envenomation with snake bite and black widow spider bites are to be considered. Now, Addison's and diabetic ketoacidosis will obviously be discussed under endocrine disorders under the loss of function category, which I'll be coming to later. Hyperparathyroidism will be discussed under disorders of calcium, phosphate, and magnesium metabolism. Hyperlipidemia will be discussed under disorders of lipid metabolism. So all these three entities will be under endocrine disorders. Um, Porphyria will be discussed under genetic disorders with a multi-system presentation. So I'll be discussing the specifics of these diseases there. Now, however, from a diagnostic standpoint, some of these disorders warrant very specific testing. So I'll just discuss that here. For Addison's disease, that implies a 7 a.m. serum cortisol level assessment, which, if it is less than 3 microgram per ml, is diagnostic. Now, 3 to 15 microgram per ml warrants an ACTH stimulation test, the detail of which we will come to later. And if there is an inability to increase serum cortisol by more than or equal to 9 microgram per ml, that again becomes diagnostic for Addison's disease. Now, for C1 esterase deficiency, we do complement testing, C3, C4, and C1 esterase levels. For Mediterranean fever, familiar Mediterranean fever, do genetic testing. Please note, other autoinflammatory monogenic disorders can also have peritonitis, particularly TRAPS can have it. Okay, that is TNF alpha related autoinflammatory okay, so TNF alpha related autoinflammatory periodic fever. Okay, so periodic syndrome. So then we have your mast cell disorders. Obviously, we check the baseline and intra-episode levels of serum tryptase levels, because that is an enzyme secreted by mast cells. And then we have acute intermittent porphyria, for which we check urine protoporphyrin and porphyrin levels. But again, this is something, the specifics of this are important, and we'll discuss this in under genetic disorders. Next, coming to your significant but poorly localized abdominal pain. Again, this may or may not be may or may not be with vomiting. Now, the thing is, it is significant, but it is poorly localized. So that's a little odd, right? Why would you have the patient have significant abdominal pain, but the patient doesn't complain or is not able to localize the pain properly? So there are actually four possible explanations for this. and we give them some clear clinical terms. So the first thing is that you could have a chronic, long-standing gastrointestinal disorder. So now, because the innervation of the gastrointestinal tract is not very discrete, it being a visceral or these being visceral organs, often when there is chronic activation, there is overlap of the receptive fields of pain. So the receptive field for the stomach starts overlapping with that for the small intestine, for example, and there is dermatobal overlap. So the patient is not able to say where exactly the pain is arising from because the brain interprets it as signal coming from multiple locations. Okay, so in that situation, we call it chronic itis with the organ of the name of the organ attached in between. So that would become chronic pancreas hyphen itis or chronic pancreatitis or similar considerations. Now, the other thing that can happen is you can have multiple areas of GI tract that are truly affected. That is a pathology that is really affecting multiple areas of the GI tract. So the patient that cannot say that it is this area and that not that area. So that happens with chronic and acute mesenteric ischemia. Okay. Then the pathology can also not be within the GI tract, it may be within the retroperitoneum, and the dermatomal distributions within the retroperitoneum are actually very non-overlapping, so that becomes difficult to differentiate. So any retroperitoneal disease. And finally, you could have a prior acute gastrointestinal disorder that has resulted in a expansion of the receptive field, just like in the first situation. But right now, the patient has no gastrointestinal disorder. So this is actually what we then term functional, and specifically this refers to functional disorders in which there is altered peripheral center sensitization. So specifically, I'm talking about irritable bowel syndrome in this particular situation and narcotic bowel syndrome. Okay, now we have intraperitoneal causes. So these causes again I like to differentiate into intraperitoneal and extraperitoneal for natural reasons. So in intraperitoneal causes, again we will get divided based on the presence or absence of vomiting. Here, patient has significant but poorly localized abdominal pain. So again, within the peritoneum, this could be actual structural disorders. So this includes your peptic ulcer disease, inflammatory bowel disease, small intestinal bacterial overgrowth, and gastritis due to any cause. Now, gastritis causes prominent vagal activation, histamine release, etc. So that is often associated with vomiting. The other three entities may or may not be associated with vomiting. Okay. Now, after structural, we have our propulsive disorders in which the emptying of the gastrointestinal tract is impaired. So that means gastroparesis and chronic intestinal pseudo obstruction. We'll be talking about these two entities separately later. So again, there is chronic distension, chronic receptor activation, therefore dermatomal overlap, which is the patient is unable to explain by themselves. Okay. Then we have the functional disorders, and the functional disorders are centrally mediated abdominal pain syndrome, functional dyspepsia, narcotic bowel syndrome, and IBS. I'll be discussing narcotic bowel syndrome and centrally mediated abdominal pain syndrome here, and we'll discuss IBS separately at a later date. Functional dyspepsia will be discussed under dyspepsia in this next video. Then we have vascular disorders which affect different parts of the intestinal tract separately. So that includes your chronic mesenteric ischemia and median arcuate ligament syndrome. Okay. So GI tract disorders that cause abdominal pain therefore are poorly localized because the chronic pain results in overlap, dermatomal overlap over a long period of time, and that that makes it difficult for the patient to localize the pain. It can also be due to actual multifocal involvement of the gastrointestinal tract, like in chronic mesenteric ischemia. Okay. Now, I'll be discussing on these three disorders, that is IBD, small intestinal bacterial overgrowth, and celiac disease under an approach to chronic diarrhea, and they will not be included in this this series. Now, the second cause are retroperitoneal structure involvement. Again, there may or may not be vomiting in these patients. So, the most important cause is chronic pancreatitis or pancreatic complications of acute pancreatitis like chronic pseudosis. Now, these cause vomiting because they can start compressing the pylorus of the stomach, causing gastric outlet obstruction. Uh, the other causes do not typically cause vomiting. I use a mnemonic for this, that is CREEP. That is CREEP stands for C for chronic pancreatitis, R stands for retroperitoneal fibrosis, E stands for endometriosis, A stands for aortic aneurysms, and P stands for primary sclerosing cholangitis. Okay, so that's how you recall these. So not only chronic pancreatitis out of these problems can cause vomiting. Now, coming to functional abdominal pain, like I said, I'll be discussing centrally mediated abdominal pain and narcotic bowel syndrome. Now, there are clear definitions to these disorders. Centrally mediated abdominal pain syndrome must be present for at least 3 months within the last 6 months. Okay, this is generally the case for functional dyspepsia also and IBD, that is IBS rather, that is irritable bowel syndrome. Now, narcotic bowel syndrome is chronic or frequently occurring abdominal pain with usually coinciding with acute or chronic narcotic, acute high dose or chronic usage of narcotics. Now, by definition, centrally mediated abdominal pain syndrome is either continuous or nearly continuous. There is not it is not related to any other type of physiological event like eating, defecation, or menses, because that would indicate that it is triggered by peripheral activation of some receptor, which it is not, as we'll just discuss in the mechanism. The pain limits some activities of the daily living of the patient. This is an important feature, and the pain is not faint, that is, the patient is not pretending, so it's true pain. So these three are very, very important. Okay, the pain has to be continuous or nearly continuous, has to cause trouble to the patient, and has to it must not be related prominently with some kind of physiological event like eating, defecation, or menses. Although there may be some degree of gastrointestinal dysfunction, so that is where it starts overlapping with irritable bowel syndrome. The problem is due in central processing of pain. So this is the gastrointestinal, correlate of essentially fibromyalgia. Okay, and there is hypersensitization within the central or the central nervous system to peripherally to pain. So as a result, the patient has appreciates pain even when there is no to minimal activation of peripheral receptors. Now, because of this, some domains of the patient's personal life or social life are affected. So there may be a problem with work, intimacy, social leisure activities, family life, and care giving either for self or for others. Okay. Now, narcotic bowel syndrome obviously must be considered only in people who are taking narcotics. The pain worsens or incompletely resolves with continued or escalating doses of narcotics. There is a marked worsening of pain when the narcotic dose wanes. That is, the when you decrease the dose, the pain worsens, but if continued usage of the narcotic also causes pain. Okay, so this is called a soar and crash. Okay. Now, the dose dependent, the result of this is basically a dose dependent inhibition followed by activation. So, the doses of narcotics that a person is, the opioid narcotics that a person is exposed to increases progressively as they get more and more, used to taking them. The sensory neurons in the dorsal root of the of the spinal cord, essentially initially are inhibited by the narcotic, so there is, a decrease in pain sensitivity, but at higher doses they start getting activated. Okay, because of activation of GS, because these receptors are G protein coupled receptors. So that is what causes the abdominal pain. Now, the most important thing is that continued narcotic usage worsens pain, but the patient keeps showing a definite pill seeking behavior. So the patient, even though there is worsening of pain, when you give the patient narcotics, the patient wants more narcotics, because when you stop the narcotics, the pain worsens. Okay. Fine. So in this discussion, we've discussed the following things. We've deduced the causes of vomiting without any abdominal pain. We've understood what are the functional vomiting syndromes. We've deduced the causes of significant and diffuse abdominal pain with or without vomiting. We've deduced the causes of significant but poorly localized abdominal pain without vomiting. And in that, we've understood the mechanisms by which such an odd thing happens. We've also enumerated the possible underlying etiologies, and we've understood functional abdominal pain. Okay, in the next discussion, I'll be proceeding to a discussion on the causes of focal or highly localized abdominal pain and how we differentiate them from each other, as well as we'll talk about dyspepsia, because dyspepsia lies somewhere in the overlap between vomiting and abdominal pain and often causes confusion when patients present like with those symptoms. So thank you for watching, and I'll see you in that video. Thank you.